Picture this. You wake up one morning feeling that all too familiar heaviness deep in your lower belly. You head to the bathroom, sit down, and you wait, and you wait, and nothing happens. You strain a little harder, still nothing. You think, maybe I just need another cup of coffee. So you get up and try again an hour later. Same result. By the third or fourth attempt, something has shifted, and not in a good way. Now there's real pain, a deep, dull, almost throbbing ache that radiates from your lower back all the way down into your pelvis. You begin to feel full, bloated, almost feverish, and a quiet little voice in the back of your mind starts whispering, something is seriously wrong. If that story sounds familiar, if you are watching this right now and that scenario hit a little too close to home, I want you to stop whatever else you are doing and pay very close attention to the next 18 minutes, because what I am about to share with you could genuinely save you from a dangerous, potentially life-threatening medical emergency. My name is Dr. Franklin, and today we are having the conversation that nobody wants to have, but that millions of people, especially adults over the age of 60, desperately need. Today's topic, stool that is physically stuck inside the rectum. What is it? How does it happen? What are the warning signs your body sends before it becomes catastrophic? And most importantly, what do you do about it right now, step by step? I promise you, by the time this video is over, you are going to understand your own digestive system in a way that no doctor has ever taken the time to explain to you. And that knowledge, that is going to be the most important thing you carry out of this conversation. So take a slow breath, get comfortable, and let's get into it. Before we get into this, I would love to hear from you. Where are you watching from today? Drop your city or country in the comments below. I read every single one, and it really helps me see who is part of this community. All right, now let us get into it. And I want to start not with the solution, but with the problem itself. Because here's the thing most people get wrong. They treat digestive issues like a dripping faucet. Ignore it for a while, stick a bucket under it, hope for the best. But what we are dealing with here is not a leaky faucet. This is more like a pipe that has completely seized up. And understanding exactly why it happened is the key to both fixing it right now and making sure it never happens to you again. The medical term for what you are experiencing is called a fecal impaction. But forget the clinical language for a moment. In plain human terms, here is exactly what is happening inside your body right now. Your large intestine, that 5-foot-long tube that winds through your abdominal cavity, has one very important job: to absorb water from whatever passes through it. It is incredibly efficient at this job, brilliantly efficient actually. The problem is that when stool sits inside the colon for too long without moving forward, your body doesn't know to stop extracting moisture. It just keeps pulling water out hour after hour, day after day. And what begins as soft, manageable waste gradually transforms into something that has the texture and density of hardened clay. Now here's the part that catches most people completely off guard. This situation almost never develops suddenly. It is not like a light switch that flips from fine to emergency overnight. What actually happens, especially in older adults, is a slow, gradual progression that builds over 3, 4, sometimes even 7 or 8 days. And during most of that time, you may feel only mildly uncomfortable, maybe a little full, maybe slightly sluggish. You might even still be going to the bathroom, but each time you go, you are only passing a fraction of what your body needs to eliminate. A little bit gets out, but a significant portion stays behind. The next day, the same thing happens. And the day after that, think of it like this. Imagine you have a garden hose and you are trying to push a large, rough, misshapen stone through it. That stone is not going to slide. It is not going to compress. And the harder you push, the more it wedges in. That is literally the mechanical situation happening inside your lower digestive tract. And the harder you strain and push on the toilet, the more you are actually compressing that mass further rather than dislodging it. But here's what I really need you to understand, and this is critically important for older adults especially. The older we get, the more vulnerable we are to this exact scenario. After the age of 60, several physiological shifts happen simultaneously that dramatically increase the risk of fecal impaction. Intestinal muscle contractions naturally slow down. Pain perception in the gut becomes less reliable, meaning you may not feel the urgency signals as clearly. Many seniors are on medications, blood pressure drugs, pain medications, antidepressants, iron supplements, even calcium. that significantly slow motility, and the natural thirst reflex weakens with age, leading to chronic low-grade dehydration that the body doesn't even register as thirst anymore. So this is not a failure of your body. It is not your fault. It is a perfect storm of biological changes that nobody ever properly warned you about. Before we begin, take a second and tell me your name and where you're tuning in from. I go through the comments and I genuinely want to know who I'm speaking to and supporting here. Now I want to spend a moment here on something genuinely important, because the symptoms of a fecal impaction can be deeply misleading, and getting them wrong can lead people to take exactly the wrong action, which can make everything dramatically worse. The first confusing symptom, watery liquid discharge. Now stay with me here because this is the one that sends the most people in the wrong direction. You might be sitting there thinking, but I'm not constipated, I actually have diarrhea. And here is the shocking truth about that. When a solid, rock-hard mass of stool completely blocks the rectal passage, the newer, looser waste coming down from higher up in the colon has nowhere to go. So it does the only thing it can do. It seeps around the edges of that solid blockage and leaks out as watery liquid. This is called overflow or paradoxical diarrhea, and it tricks people into thinking they have a stomach bug or a GI infection rather than a blockage. The danger in this, people reach for anti-diarrheal medications, and those medications, the kind that stop intestinal movement, are absolutely the worst thing you can take in this situation. They don't just stop the liquid output, they slow the entire digestive system, allowing the impaction to continue hardening and growing. If you have watery discharge along with a heavy, aching feeling of rectal fullness, do not touch anti-diarrheal medication, please. The second confusing symptom involves your bladder, and this one surprises almost everyone. You may suddenly find yourself struggling to urinate. You feel the urge, you go to the bathroom, but only a painful trickle comes out. Or you find yourself needing to go every few minutes, but barely producing anything. This is not coincidence. Your rectum and bladder are anatomical neighbors. They share a very confined pelvic space. When your rectum is distended and swollen with a large hardened mass, it physically compresses the bladder wall from behind, partially blocking the urethra and making normal urination difficult or even impossible. In severe cases, this urinary retention becomes a medical emergency in its own right. The third symptom that gets overlooked is lower back pain, a deep, nonspecific aching in the lumbar region that doesn't seem connected to your bowel at all. Many people assume they pulled a muscle or that it's their arthritis flaring up. But when rectal pressure builds to a significant level, the pain radiates outward, into the lower back, down into the thighs, even into the hips. If you're experiencing unexplained lower back discomfort alongside any bowel irregularity, that combination is a red flag worth taking seriously. And the fourth symptom, especially relevant for older adults, sudden changes in mental clarity or confusion. This one sounds strange, I know, but there is substantial clinical evidence showing that in seniors, significant bowel obstruction can contribute to what looks like a cognitive episode, disorientation, mild confusion, unusual agitation. This is due to the systemic physical stress and discomfort the body is under, combined in some cases with early toxic buildup. If an older loved one seems suddenly off mentally without obvious cause, always consider their bowel status as a contributing factor. If this is the kind of information nobody ever told you before, hit subscribe right now because there is a lot more where that came from. And trust me, what comes next, you need to hear. Let me be straightforward with you now because I believe you deserve the truth delivered clearly, not wrapped in gentle language that softens the message into something that doesn't land with the gravity it deserves. A fecal impaction is a genuine medical emergency, not a nuisance, not something to wait out. If left unaddressed, the consequences escalate in a very predictable and very serious pattern. Stage 1. The intestinal wall, which is living muscle tissue, becomes severely stretched beyond its functional capacity. Blood supply to that stretched tissue begins to diminish. The muscle begins to lose its ability to contract and push waste forward. Essentially, that section of bowel starts to go quiet, what clinicians call an ileus. Stage 2. As pressure continues to build, the distension can spread upward, affecting higher sections of the colon. What started as a localized rectal impaction can evolve into a broader colonic obstruction. Nausea and vomiting begin. Abdominal distension becomes visible. The person looks and feels genuinely ill. Stage 3, and this is the one I need you to hear clearly, is bowel perforation. The intestinal wall has physical limits to how much it can stretch. When those limits are exceeded, the wall tears. And when that happens, the contents of the bowel, fecal material, bacteria, toxic byproducts of digestion, spill directly into the sterile abdominal cavity. What follows is a rapidly progressing infection called peritonitis, and it is life-threatening. Without emergency surgical intervention, it is fatal. I am not sharing this to frighten you. I am sharing it because the stakes of ignoring this condition are real, and you have every right to understand them clearly. The window between serious but manageable and life-threatening emergency is not as wide as most people assume. So what does the danger zone actually look like from the inside? Here are the signals that mean you need to call 911 or get to an emergency room without delay. A rigid, board-like abdomen that is tender to the touch. A high fever above 101 degrees Fahrenheit. Sudden, severe abdominal pain that is constant and worsening, not crampy and intermittent. Complete inability to pass gas at all. Vomiting that does not stop. Or any sudden drop in blood pressure accompanied by confusion and cold, clammy skin. These are not wait-and-see symptoms. These are go-now symptoms. All right, let's shift gears from the why into the what do I actually do right now, because knowledge without action doesn't help you. And I want to give you a clear, logical sequence that you can follow starting tonight if necessary. The very first thing I need you to do, and I cannot say this strongly enough, is stop straining. Put the brakes on. Every time you bear down and push hard with a solid impaction blocking the exit, you are not helping. You are increasing intra-abdominal pressure, irritating already inflamed tissue, and risking hemorrhoids or small rectal tears. Straining will not move a fecal impaction. Not one single time in human history has white-knuckling it on the toilet dislodged a hardened mass, so we are going to stop doing that right now. Step 1. Lubrication and softening with glycerin suppositories. Your first at-home intervention is adult glycerin suppositories, which are available over the counter at any pharmacy without a prescription. Now here is the crucial piece of information most people do not know. For a significant impaction in an adult, a single suppository is rarely sufficient. The standard protocol for a hardened rectal blockage in adults involves using 2 to 3 suppositories simultaneously. One alone simply may not generate enough lubricant to coat and soften a large dehydrated mass. Here is exactly how to do this correctly. First, do not stand up. Lie on your left side. This specific position, called the left lateral Decubitus position, aligns the sigmoid colon and rectum in a way that allows gravity to assist rather than work against you. It also takes direct pressure off the rectal area. Next, apply a generous coating of a water-based lubricant to each suppository before insertion. Do not skip this step. The tissue inside your rectum is already irritated and inflamed, and dryness at this stage makes everything more painful and more difficult. Gently but firmly insert all 3 suppositories as deeply as possible. You want them pressed up against or alongside the hardened mass, not sitting near the entrance where they'll simply fall out. Then, and this is the most important instruction, lie still. You must hold this position for a minimum of 30 minutes, ideally 45 minutes. The glycerin needs time to melt at body temperature, disperse, and penetrate the outer surface of the impacted mass. It also needs time to stimulate the rectal wall to increase its own secretions. If you jump up and run to the toilet after 5 minutes, you accomplish nothing except wasting the suppositories. After your 30 to 45 minutes, rise slowly, go to the bathroom, and allow your body to work without forcing anything. If there is movement, wonderful. If not, stay calm. Do not be aggressive. Step 2. Rest, walk, and repeat. If the first round produces no movement, give your body a full hour of rest. Stand up, walk gently around your home, drink a full glass of warm water. Warmth helps relax the intestinal muscle, and then lie back down and repeat the suppository process exactly as described. A second round is frequently what finally breaks through. The first application often softens the outer layer of the blockage. The second round reaches the core. If you're still here with me and finding this helpful, take a moment to type 2 in the comments. It lets me know you're watching and getting value from this. Step 3. If home measures fail, it's time to go. I want to be unambiguous here. If you have completed 2 full rounds of the protocol I just described, waited the appropriate amount of time, and there is still no movement, or if you are experiencing any of those emergency symptoms I described earlier, it is time to go to urgent care or the emergency room. This is not defeat. This is the correct clinical decision. At the hospital, the medical team has access to clinical-grade enemas that use larger fluid volumes and are delivered under controlled pressure, reaching further into the colon to break apart the mass from above. They also have imaging tools to assess just how extensive the blockage is and whether there is any risk to the bowel wall. Step 4. Manual disimpaction. In cases where all other interventions fail, a specialist will perform what is called manual disimpaction. I want to be transparent with you about this procedure because it sounds alarming, and knowing what to expect removes some of the fear. The physician will physically break up and remove the hardened mass digitally, meaning with gloved, lubricated fingers. In cases where the impaction is severe and the surrounding tissue is significantly inflamed, this is not done in a standard exam room while you're awake. You will be given appropriate sedation or anesthesia to prevent pain and allow the rectal muscles to fully relax. It is a serious procedure, but it is a safe, well-established clinical intervention, and the relief that follows, the immediate dramatic drop in pressure and pain, is described by patients as profound. Clearing the current blockage is essential, but I would be doing you a disservice if I stopped there. Because if we don't address the conditions that created this situation, you will be back here, probably within weeks. And after the second time, the third time comes even faster. This is how chronic fecal impaction becomes a repeated cycle that gradually worsens with each episode. So let's talk about how to genuinely protect your digestive health for the long term, especially if you are over 60, when the biological factors I described earlier are actively working against you. Number 1, hydration is not optional. It is the foundation of everything. Water is the single most important variable in preventing stool hardening. Your large intestine extracts water from waste as its primary function. If you are not consistently giving your body enough incoming hydration, there simply is not enough moisture in that waste stream to keep stool soft as it travels. The challenge for seniors is that the thirst reflex genuinely diminishes with age. You may feel completely fine and have no sense of thirst whatsoever, and still be chronically dehydrated at a cellular level. The practical recommendation: do not wait until you feel thirsty. Drink 6 to 8 glasses of water throughout the day, including a full glass first thing in the morning before you eat or drink anything else. That morning glass stimulates what is called the gastrocolic reflex, a gentle wave of intestinal movement triggered by fluid entering an empty stomach. It is one of the most natural, medication-free ways to encourage regular morning bowel movements. Number 2, movement matters enormously. Your intestine is not a passive tube. It is muscular tissue that moves waste through a rhythmic, wave-like contraction process called peristalsis. And here is something that most people do not realize. Physical movement of your body directly stimulates peristalsis. A 20 to 30-minute walk after meals, even gentle, comfortable walking, has been clinically demonstrated to significantly accelerate intestinal transit time. For older adults who are more sedentary due to mobility limitations or chronic pain, even chair exercises, gentle yoga stretches, or simple torso rotation movements can help keep intestinal muscles active. Prolonged sitting, especially after eating, is one of the most underestimated contributors to constipation in seniors. Number 3, review your medications with your doctor. This one is non-negotiable. A wide range of commonly prescribed medications, including opioid pain relievers, certain blood pressure medications called calcium channel blockers, iron supplements, calcium supplements at high doses, antidepressants, diuretics, and antihistamines, are known to significantly slow intestinal motility. This doesn't mean you should stop taking your medications. It means you should have an honest, specific conversation with your physician about your bowel function. Ask them directly, could any of my current medications be contributing to constipation? And if so, are there alternatives with less impact on my digestive system? Many doctors simply do not bring this up unless you ask. You need to be the one who raises it. Number 4, be very careful with stimulant laxatives. I want to take a moment here to address something that I see cause significant harm in older patients because it seems counterintuitive at first. Stimulant laxatives, the kind that chemically force the intestine to contract, are useful in genuine short-term situations. But when they become a daily crutch, something troubling happens. The intestinal muscle begins to depend on that external chemical stimulation to initiate movement. Over time, without the laxative, it simply does not contract. This is called cathartic colon or laxative dependency, and it is far more common in older adults than most people realize. If you have been using stimulant laxatives daily for more than 2 or 3 weeks, please speak with your doctor before stopping abruptly and work together to wean off them and rebuild natural motility through the other methods I've described. And if you've made it this far and you're getting value from this, type the number 4 in the comments. It's a simple way to let me know you're here and following along. Number 5, establish a consistent bathroom routine. Your body has a natural internal clock, and your digestive system follows circadian rhythms just like your sleep cycle. The gastrocolic reflex is strongest in the morning, particularly within 30 minutes of waking and within 30 minutes of eating breakfast. Use that window every single day. Go to the bathroom at the same time each morning, whether you feel a strong urge or not. Sit down, relax, and give your body 5 to 10 minutes. Over time, typically 1 to 3 weeks, your body begins to synchronize with this routine and initiates movement on its schedule. Consistency is the training tool. Don't skip days. And finally, posture matters more than you think. The human body was not designed to defecate from a seated position with the thighs at a 90-degree angle to the floor. Physiologically, a slightly squatted position, thighs angled upward toward the abdomen, fully relaxes the puborectalis muscle, a sling-like structure that otherwise creates a natural kink in the rectum. A simple step stool under your feet when you sit on the toilet, raising your knees above hip level, can meaningfully ease the mechanics of evacuation. It sounds almost too simple to make a difference, but for many people, especially older adults with weakened pelvic floor muscles, this single change produces a dramatic improvement. Before I close, I want to address a group of viewers who may not be here for themselves, but for someone they love and care for, an aging parent, a spouse, a sibling. Because fecal impaction is disproportionately common in bedridden or mobility-limited elderly individuals, and the people who recognize the problem first are often their caregivers. If you are caring for an older adult who has not had a meaningful bowel movement in 3 or more days, who is complaining of abdominal pressure or lower back pain, who seems unusually uncomfortable, confused, or agitated, do not assume it will resolve on its own. The stakes in a frail, elderly individual are higher than in a younger, otherwise healthy adult. Their intestinal walls are less resilient. Their ability to communicate the severity of their discomfort may be limited, and the cascade of complications I described earlier can progress more quickly. Proactive steps include offering warm fluids frequently throughout the day, gently assisting with movement or repositioning to encourage abdominal stimulation, using a glycerin suppository early, at day 2 or 3 of no movement, not day 6. And if there is any doubt, contact their physician or bring them in for evaluation. A simple abdominal X-ray can confirm the presence and extent of a fecal impaction in minutes. Please do not be embarrassed on their behalf. This is a clinical medical reality that affects a significant percentage of elderly adults in both community and care facility settings. The conversation may feel awkward, but the consequences of silence are far worse. We covered a lot of ground today, and I want to briefly recap the most important things I need you to walk away with. A fecal impaction, stool that is physically stuck in the rectum, is not a minor inconvenience. It is a serious medical condition that develops gradually, disguises itself with confusing symptoms, and can escalate to life-threatening complications if ignored. The warning signs to watch for: persistent rectal heaviness and difficulty passing stool, overflow liquid discharge that looks like diarrhea, difficulty urinating, lower back pain, and in older adults, unexplained confusion or agitation. The emergency response protocol: stop straining immediately. Use 2 to 3 adult glycerin suppositories with generous lubrication lying on your left side and wait a minimum of 30 to 45 minutes. Repeat once if necessary. If home measures fail, go to urgent care or the emergency room. Do not wait. And for the long term, prioritize water intake above all else. Move your body daily, review your medications with your doctor, avoid laxative dependency, establish a consistent bathroom routine, and use a footstool to improve your posture when you go. Your digestive health is not a small thing. It is deeply connected to your energy levels, your immune function, your mental clarity, and your overall quality of life. And yet, it is one of the most consistently neglected aspects of senior health because people are embarrassed to talk about it. Well, we just talked about it, and I hope you feel better informed, less alone, and more empowered to take action. If this video helped you, please hit the like button. It genuinely helps this information reach more people who need it. Share it with someone in your life who you think might benefit. Leave a comment below with any questions you have, and I'll do my best to get to them. And subscribe to this channel if you want to continue receiving straightforward, honest senior health education that doesn't talk down to you and doesn't hold back the important information. Take good care of yourself, drink your water, and I will see you in the next one.